So now let's take a look at another clinical vignette. Here's a 48-year-old man who comes to see you for advice about vaccinations and travel medicine before traveling to a far-off land. He doesn't tell you where he's going. He just tells you it's very, very far away, which makes you suspicious, but we're not going to get into that. Anyway, he feels well, no symptoms, and he takes no medications. On exam, you find his blood pressure is 118/76, which is perfectly normal. However, his pulse is 40 beats per minute, which is low. So this patient has bradycardia. However, he has no symptoms, so this is asymptomatic bradycardia. So bradycardia is defined as a heart rate less than 60 beats per minute. However, bradycardia is not always pathological. Let's take a look at some etiologies. Trained athletes are bradycardic at rest, and there's nothing to do about that. It's actually a good thing to have bradycardia if you're an athlete. Now, tachycardia is not such a great thing. Bradycardia is a great thing. So for trained athletes, bradycardia is perfectly fine and perfectly normal. Patient can be bradycardic because they're on beta blockers or the non-dihydropyridine calcium channel blockers, which include verapamil or diltiazem. Patients may also have sinus node disease, or they can have a heart block secondary to AV nodal disease. Myocarditis can lead to bradycardia. Infiltrative diseases. When I say infiltrative diseases, I mean hemochromatosis, sarcoidosis, or amyloidosis. All of these can lead to bradycardia because they lead to interruption of AV nodal conduction, leading to bradycardia. Also, some infections, and the classic one that they will ask you about on the USMLE is Lyme disease. Lyme disease can lead to AV nodal blocks, and the antibiotic of choice for Lyme disease that has AV nodal conduction delays is which antibiotic? It is not doxycycline. The answer is ceftriaxone. So if they give you a question where a patient has an AV nodal block due to Lyme disease, the answer is ceftriaxone. The answer is also ceftriaxone for patients with Lyme disease that have meningitis. So Lyme meningitis and AV nodal block due to Lyme disease, the treatment is ceftriaxone, not doxycycline. Other causes we went over before when we spoke about the H's and the T's in the ACLS section. Clinical presentation and diagnosis. So again, pulse less than 60 is the presentation. You can have wide symptomatic range. Patients may be completely asymptomatic. They may have severe symptoms. When I say severe symptoms, I mean hypotension. That is a severe symptom. Any patient that has hypotension due to bradycardia, that's a problem. That's a severe symptom, and that needs to be treated emergently. That is a medical emergency. If the bradycardia is so severe that they may have decreased cardiac output and heart failure, that is also a problem. So that is a case where you need to treat them immediately. You must confirm the diagnosis with a 12-lead EKG in every patient, and you should be able to recognize the EKG strips of heart block, which we will go over in this section. This is a rhythm strip of first-degree heart block. Now, first-degree heart block can be caused by medications, such as beta blockers and calcium channel blockers. Again, and if you have an overdose due to beta blockers, what is the treatment? How do you treat beta blocker overdose? If you said glucagon, that is the correct answer. If a patient overdoses on a beta blocker, the answer is you give them glucagon. If a patient overdoses on a calcium channel blocker, what is the management of calcium channel blocker overdose? If you said calcium, that is the correct answer. You would give a patient calcium. So, first-degree heart block can also be caused by Lyme disease, and we spoke about the treatment there. It also can be caused by ischemia. The most common cause is due to ischemic heart disease. And to diagnose a first-degree heart block, you just see PR prolongation on the EKG. Now remember, the PR interval tells you AV nodal conduction. The PR interval tells you AV nodal conduction. So if there is a prolongation of the PR interval, that means that there is a conduction delay of the AV node, and that can most commonly be caused by ischemia. Now if you take a look on the EKG, typically one big box is the normal length of the PR interval. So if you see a PR interval longer than one large box on the EKG, that is a prolonged PR interval. And you can see this here, that this PR interval is longer than one large box. So this is a prolonged PR interval. The normal PR interval on an EKG should be anywhere from 0.12 seconds to 0.21 seconds, or 210 milliseconds. So the normal PR interval should be no more than 210 milliseconds. If you see that, that is a definition of prolonged PR interval. And again, that means that there is a AV nodal conduction delay. And that is a prolonged PR interval. This is a first-degree heart valve. Okay, so let's take a second to look at this EKG. I want you to take a look at this EKG and tell me exactly what you see. Let's start by looking at the PR interval. So there's a P wave, and here is your QRS. So let's take a look at the PR interval right here. And you can see the PR interval here is prolonged because it's bigger than one large box. Then you go over to the next one, and what you want to look at here is you want to see, is the PR interval becoming prolonged? Is it becoming longer with each successive QRS? And if you look closely, you can see that it is becoming longer. And then you look at the next QRS complex. There's your P wave, there's your QRS, and here's your PR interval. And if you take a look here, you can see that once again, the PR interval is becoming longer. Then, what do you see next? There's a P wave, and where's the QRS? Oops, it's gone. It's not there. So there's your drop beat. So again, you see the PR intervals are becoming longer and longer. Your PR intervals are becoming more and more prolonged. And then eventually, you see a P wave without a QRS. The QRS is missing. So what's your diagnosis here? If you said Mobitz type 1, you would be correct. This is a Mobitz type 1. Now I want you to take a look at this, and I want you to be very clear on this. I want you to be careful. When you take the USMLE, do not get this question wrong. Make sure that you can look closely. I've seen many students make this mistake. Make sure you can see the PR interval becoming prolonged. If you're unclear, when you take the exam, you will have a whiteboard with a marker. What I want you to do is hold it up against the screen. You're allowed to do this, and put a mark next to the P wave, and then put one mark next to the QRS, and then slide it over. And then you'll see that the second mark will be shorter of where the QRS complex is. And that means that the PR interval is becoming prolonged. So that's a quick and easy way to be certain that you are seeing prolongation of the PR interval as you go along. And you want to do this correctly. You do not want to make this error on the exam. So that is a little hint that I would use if I was taking the exam. And this is a Mobitz type 1. So now let's take a look at this EKG. Here's your P wave, there's your PR interval. There's another P wave, there's your PR interval. This time you will notice that you do not see the PR intervals becoming more and more prolonged. What you're seeing here, that is a T wave. So there's a T wave, there's a P wave, and oops, where's the QRS? It's missing. There's a P wave, there's a QRS, another P wave, another QRS. Again, you do not see prolongation of the PR interval here. And then you see a P wave with a drop beat. So what's your diagnosis here? If you said Mobitz type 2, you would be correct. This is a Mobitz type 2. So once again, if you're on the exam and you're not certain if the PR intervals are becoming prolonged, do a little trick I taught you. Hold up your whiteboard against the computer, put your little marks with your marker, and slide it over to make sure that there's no change in the PR interval. Mobitz type 1 and type 2 are both a high yield topic, and I expect you will see this on the exam, so make sure you can recognize both of these EKGs. Okay, now let's take a look at this EKG. So let's take a look here, and this is where some students get a little confused, so let's look at this nice and slowly. What you see here is a P wave, that's another P wave right there. Then you see one QRS. The first thing I want you to notice is look how far apart the QRSs are. That's one QRS, that's another QRS. So your so-called R to R interval is massive. I'm not going to sit here and count it out, but if you want to take a quick look, the rate, the R to R interval, or the ventricular rate, remember the R to R interval tells you the ventricular rate is very slow. It's going to be about 20. The R to R interval tells you what the ventricular rate is, and here on this EKG it's about 20, so that's very slow. The P waves, if you looked at the P waves, this is actually a P wave that's buried underneath the T wave. So if you look at the P wave, the P to P interval is 100. The P to P interval tells you the atrial heart rate. So now what you have is an atrial rate of 100 and a ventricular rate of 20. That is a third-degree heart block, or a complete heart block. Complete AV nodal dissociation means that there is no communication between the atria and the ventricle. They are each doing their own thing. There's no communication between the two of them. The atria are beating at a rate of 100 beats per minute, and the ventricles are beating at a rate of 20 beats per minute. Now, on a normal EKG, every QRS interval should be preceded by a P wave. Normal conduction goes, atria contracts, then ventricle. Therefore, on EKG, you should always see a P wave before QRS. You do not see that here. You clearly do not see that here. This is complete AV nodal dissociation. The atria are beating at a rate of 100. The ventricle are beating at a rate of 20. Now, I want to make one more important point here. When you see the QRS interval, notice that the QRS intervals are narrow. You do not see a widened QRS interval in this EKG. This means the conduction delay is purely in the AV node. So there is an AV nodal conduction delay, most likely due to ischemia. But once the impulse gets past the AV node, there is normal ventricular conduction, meaning after the AV node, the ventricle is functioning just fine. The ventricle conduction is completely normal because you have a narrow QRS. So the problem is in the AV node. In this EKG, in a third-degree heart block, there is no AV nodal conduction. There is complete ischemia of the AV node, and there's no AV nodal conduction. The ventricular impulse is coming from the ventricle. It's originating from the ventricle, and once that impulse fires through the ventricle, it goes through the bundle of His and Purkinje fibers, which gives you a rapid conduction, and that's why you see a narrow QRS. So the ventricular conduction is going through the bundle of His and Purkinje fibers, and that is not the issue. The issue is that the AV node is not conducting. In this EKG, there is no AV nodal conduction at all. So now let's discuss management. In general, if you have an asymptomatic patient with bradycardia, we do not treat them, especially if they're an athlete. But even in general, if you have asymptomatic bradycardia, we typically do not treat. Now, they could have sinus bradycardia with normal PR intervals and normal AV nodal conduction. They can have a first-degree AV block, or you can have a Mobitz type 1, or what we also call winky back. If you have a first-degree heart block or a Mobitz type 1, we actually do not treat these patients. They do not get a pacemaker. There is no treatment for these patients. What you do is you avoid agents that can prolong the conduction, like beta blockers or verapamil or diltiazem, but otherwise there's no treatment for these patients. Now let's talk about what you do with severely symptomatic bradycardia. In any patient with symptomatic bradycardia, the first step is always atropine. Atropine is always the first step in any patient with severe symptomatic bradycardia. So if they're hypotensive or they have severe symptoms like lethargy or dizziness, the treatment is atropine. If that fails, the next step is transcutaneous pacing. Now, we do transcutaneous pacing and not transvenous pacing because of time delays. It takes time to do transvenous pacing because you have to put a line in. So transcutaneous pacing is much faster. So we do transcutaneous pacing before transvenous pacing, always, simply because transvenous pacing takes too long. If they still have hypotension, then you can give pressors like dopamine or epinephrine. Conditions that require a pacemaker include a second-degree heart block or Mobitz type 2 and a third-degree heart block. In those cases, you must give them a permanent pacemaker. Now, the difference between a first-degree, second-degree, and third-degree is the level of ischemia. All three of them will have ischemia, but there's different levels of ischemia. Ischemia at different points in the AV node, but all of them have ischemia somewhere in the AV node, and the different levels of ischemia in the AV node will give you a first-degree, second-degree, or third-degree heart block. And that's the difference physiologically. And the treatment difference depends on what degree you're dealing with. This slide briefly summarizes bradycardia. Patient presents with a heart rate less than 60. What is the first thing you do? Well, assess them clinically. Again, look for symptoms. Maintain an airway, give oxygen, always get a 12-lead EKG, that's very important. Establish IV access. Then speak to them about signs or symptoms. If they have severe symptoms like altered mental status, chest pain, hypotension, if they're in heart failure, if they're volume overloaded, then you'll have to react. If they have no symptoms, you just observe them. If they have symptoms, again, the first step is always atropine, because atropine is quick and easy. Atropine works in some cases. If you have an advanced heart block, like a second-degree heart block or a third-degree heart block, atropine will most likely not work. However, we try it anyway. So the first step is always atropine, but just realize if you're dealing with a Mobitz type 2 or a complete heart block, it will probably not work, but there's no harm in trying. After the atropine, you would go for transcutaneous pacing, and then if that doesn't work, you would consider dopamine or epinephrine. And then eventually you would do transvenous pacing. That is the order for bradycardia.